everybody, welcome back to TraumaCast. I know it's been a while since we had our last recording, and we have a few changes. As you can see, we have a new look to TraumaCast, and we also have a new trauma program manager, Brad. You want to introduce yourself, Brad?
Sure. Hey, everybody. My name is Brad Garman. I am the new program manager for trauma and burn surgery. Super happy to be here. I come from an ICU nursing background, but also as a 20-year paramedic with some flight experience. So interested in being a part of this team. It's a great place to work and just really excited to be here and talk with Joanna about pretty cool topics on a podcast. I think I've been told this is the only part of my job is just basically to do this. So I'm super excited.
Yeah, that's not true. We all know that. But we are so happy to have Brad to join our team to lead our trauma program. And so, to kick off our new trauma cast, what are we going to talk about today?
Well, today I thought it'd be really good to talk about what used to be known as the trauma triad of death, which has now, gotten an extra leg to it. So now we call it the lethal diamond. And we're going to break down this deadly interplay between the physiologic derangements of hypothermia, acidosis, coagulopathic conditions, and hypocalcemia, and how those kind of affect our trauma patients.
Yeah, and it's such a critical thing to understand, right? Because it's so specific to trauma patients and the traumatic injuries that they incur. And so, to start off our talk on this lovely diamond to help us understand the pathophysiology of like trauma injuries for our patients, we're going to start with temperature. Why is temperature so important with when dealing with our trauma patients?
Yeah, I think, a lot of it has to do with mechanism. I mean, like, patients that are traumatically injured, especially pediatric patients, they tend to lose temperature for a variety of reasons. They have a decreased amount of fat stores, their body surface area, the ratios are entirely different than adults. And then a lot of them, depending on their age, especially the young ones, they really can have an immature um, thermoregulatory system as well. So we know that these kids, they end up getting colder faster. And that leads to bad outcomes, which for me, especially coming pre-hospitally and like in emergency care, was this like strange thing because I always thought that like the important vital signs were like blood pressure, maybe heart rate, pulse ox or something. But apparently temperature also kind of is a part of that.
Yeah, and it's so important because a lot of times we don't know how cold our patients are coming in, and sometimes even, especially during the summer, we think that everybody's going to be coming in warm because it's so hot outside. It's usually like in the 90s to hundreds, and you think we're hot, so they should be hot because the ambient temperature is hot, but because of the nature of the injury, they usually do come in cold, and like you said, does lead to worse outcomes. And it's not usually the first vital sign we do think about when trauma patients come in because you're like, well, what's their hemodynamic status? What else do we need? Do we need what's their airway? We're going down ABC, but temperature is definitely one of the vital signs that is a key indicator for survivability.
Yeah, it
Uh,
actually carries like a two times mortality, I think, and an increased ICU stay. There's been like a good amount of studies that we've seen, and in looking at our like global pediatric trauma database, we actually find that hypothermia on ED arrival was a very strong predictor of mortality, even greater than things like hypotension, depending on the age group. It can show worse neurologic outcomes, and then, of course, because we are talking that all this stuff is on a diamond, that it actually is all related too, which we'll kind of get in a little bit later. So, we do a lot of PI work around this stuff within our department, and temperature assessment, documentation, actually getting one is a challenge in the trauma bay. I think we actually, Joanna, correct me if I'm wrong, but like I actually believe that the sicker you are at Children's, usually the more difficult it is for us to accurately and continuously assess your temperature.
Yeah, I think our average rate of getting a temperature on our trauma stat attending is about 70%. So we do not get temperatures on 70% of our trauma stat attendings. And if you think about that, they're the sickest of the sick patients that come through. They're probably the ones that have the higher propensity to be hypothermic. And so, because we don't have a baseline temperature, we don't know where they stand, they tend to get colder because we're not recognizing that they're cold, and then we're not doing anything to warm them up. What do we have in the trauma bay to help correct the hypothermia?
Well, we do a few things kind of proactively on in our trauma bay. On the stretcher itself, there's actually a bear hugger on the stretcher, and so every patient, trauma patient that comes into the bay, is actually placed on this bear hugger to increase kind of radiant temperature, and obviously with the contact with that. That's kind of like our main thing. Obviously, when they come into the bay, one of the first things we need to do is expose them to look for catastrophic hemorrhage and critical injury. We kind of like pull that back a little bit, but then quickly as we move forward in the trauma assessment, we do try our hardest to start warming these kiddos up. But like I mean, like data drives change, right? So what can you say from like a PI perspective, that are we doing with temperature now? Where do you see this going? What kind of things are we looking to do here that could maybe improve our ability to monitor this process of checking and controlling temperature?
Yeah, so earlier this fiscal year, we realized a lot of patients, our trauma sat attending patients that had major injuries going to the PICU were arriving to the PICU cold. So we decided to look at the data, right, and look at what it looks, where we are missing the mark. And we noticed that the temperatures weren't being assessed in the trauma bay. So we are looking to see how we can change that, how we can assess the temperature like initially, but also we're looking in ways to continuously monitor temperature. So, getting a probe that we can either place in the esophagus or a rectal probe, so that we can actually in real time see where the drop in temperature happens, and what if the things that we are doing is helping, especially using the Belmont, using the bear hugger, placing warm blankets on the patients, and seeing what we can do to help the survivability of the patients. And hypothermia is because that's the first thing that we can actually make a difference on, right? As nurses, we're not ordering meds or anything. It's the temperature that's one action we can do that doesn't require additional resources.
Yeah, for sure, for sure. Temp's important. I think that's the hit home, right? You got to treat it like a critical vital sign, and it's not just an effect, right? So, all right. Well,
Sure.
that's the first one. So let's kind of move on to the next step, the next stage, if you will, and take a look at the next part of the diamond, which is acidosis. And coming from the ICU and from critical care, this is near and dear to my heart, about managing acidotic patients. And so, in trauma specifically, these patients come in with some level of acidosis, either from some sort of ventilatory compromise. Yeah, we see this a lot often in patients with prolonged downtime, and also patients who maybe have prolonged extrication times inside of a vehicle. And so there is always that opportunity for a respiratory component. More often, when you look at the trauma literature and you start talking about acidosis in trauma patients, we're really talking about a metabolic acidosis, specifically a high lactate induced metabolic acidosis, and it's bad. Go figure. Lactate in patients has been shown to negatively affect a lot of outcomes, including mortality. We know that early lactate acidosis has a massive increase in mortality, even as little as a lactate of 4. It accounts for longer ICU stays, worsening neurologic outcomes. So it's absolutely something that we want to try to address in the trauma bay, whether it's a ventilatory problem that we can correct quickly by proper ventilation and securing an airway, or by understanding that lactate is being is the result of an anaerobic metabolism because of some sign of poor perfusion, organ damage, or something like that. And so, like, correcting lactate in the trauma bay can be a challenge, and it's actually very different than correcting lactate in, like, the ICU, for example.
Right.
Yeah.
How do we correct lactate or even just acidosis?
Yeah. Well, your school books and whatever will tell you that you fix a metabolic acidosis with sodium bicarbonate, but as someone who is a really aggressive anti-bicarb guy, I can tell you that sodium bicarb is really not indicated whatsoever in the trauma bay. For almost all of our patients, and specifically those with a lactic acidosis. A lot of times, if we're running VPGs off these patients and we're taking a look at them, we do find that sometimes, just because it's like a knee-jerk reaction from like your medical practice and pathways, that somebody calls for a sodium bicarbonate administration. However, a lot of times with sodium bicarbonate and a lactic acidosis, it actually can make the lactate accumulation worse. And then you include as well this idea that, patients who are unable to ventilate also can't clear that CO2. And so it's all connected. And so it's really important that you look at lactate clearance from a fluid resuscitation standpoint, choosing the right thing to resuscitate with. We know that much of our crystalloid is very acidic at baseline. And so you really need to have the lactate be that driver for how you're going to fluid resuscitate these patients, stop the bleeding, and re-engage the body's normal pathway of aerobic metabolism. Yeah. And so what we talk about, and that is this idea of like goal-directed therapy. So we use that phrase a lot when we're talking about a lot of things, but lactate clearance is a great example of goal-directed therapy inside of the trauma bay. And so whether it's a surgical intervention or whatever, when you have a lactic acidosis, fluid resuscitate and address the underlying cause, whether that be a surgical intervention or not. Which can sometimes be a problem because these patients bleed, don't they, Joanna?
Oh, they do. So coagulation is the third part of the diamond of death, right? And so there's something called the trauma-induced coagulopathy, right? What does that mean? There's like the decreased ability to clot, right? You have, whether it's tissue injury, dilution, whether it's coming from hypothermia, this is all interrelated, right? And so we do have data that shows that patients with the abnormal coagulation,
You got
have a 2 to 4 times higher mortality rate. So even when we try to control the injury, control the cause of it, because there's an inability to go through the cascade properly, they are at a higher risk of mortality. So why do trauma patients get coagulopathic, right? So there's definitely the actual injury, the severe trauma that causes the systemic inflammation and the endothelial damage, right? But then, so the damaged endothelium activates the protein C pathways, going very granular into the inhibition of the clotting factors, right? That promotes fibrinolysis.
You got the hard one, I think. I think you got the hard one.
But then you also have the hepatic injury, right? And then you have blood and plasma loss when you have because of the injury, and then you have that causes the large trauma-induced cause because you're depleting all of your good stuff. You're bleeding out somewhere. But also we have an issue with when we try to resuscitate these patients, we provide them with crystalloids. And the famous Jen saying is we don't bleed saline, right? So why are we replacing with saline? We need to replace with blood products that will help with the coagulation, and and give back the goodies that you lost, right? You want to make sure that we are giving the body what it needs. And so, how do we correct it, right? We have to first find what's causing it, stop the bleed, right? We have tourniquets, we have things in place that places think what's the thing that we use that we put on bleeds. Now it's escaping me, but the
Quick
gauze
clot,
and
quick clot.
thank you. That we can place onto the injury, or even identifying where it's bleeding so that we can take them to the OR so surgery can do their thing to stop the bleed wherever it's starting. We are replacing what they're losing with blood products, whether it's we definitely can start a massive blood transfusion in the code room, starting with PRBC, giving balanced resuscitation, right? So PRBC, FFP, and then platelets following that massive blood transfusion protocol. TXA is a great adjunct to also provide. We do have that in the trauma bay as well as throughout the hospital, and our clinicians definitely know to start that when there is a massive bleed. And we also have, starting this past year, we have trauma tags, so we can actually pinpoint the products that they need, that's being lost or the body is unable to provide, that we can pinpoint the products that is necessary to help with the coagulation to help the coagulopathy.
Yeah,
Did
I
I
think
miss anything, Brad?
I don't think so. This is the one for me, especially, that I think is like one of the more complex, pathways when you look at like the pathophys of the whole thing. And like, I think, in earlier stages of my career, like understanding that there's a clotting problem with patients who are traumatically injured made sense to me because, I would arrive on an ambulance or in a helicopter and I would see all their blood that should be inside of them next to them. And so that kind of all made sense, but never really like took the time to understand that it's really a multi-factored failure point when you have these issues, because you've got this epithelial damage is like triggering your body to like start using clotting factors, and then all of a sudden all that stuff starts going out of whack and overdrive. You start running into DIC problems, and it becomes such a problem because having patients who are prone to bleeding makes trauma surgery a really risky thing, especially when we talk about neurosurgical interventions in our patients with traumatic head injury. So it really is something that we need to try to get a hold of quickly when we can. I think for the most part, providing proper balanced blood product resuscitation so that they can get those factors reestablished is probably one of the best things we can do besides stopping the bleeding. But this creates such a challenge for us. It's why, traumatic patients, aren't always ECMO candidates depending on your center and what your protocols are, because they're just so prone to both bleeding and clotting. And it is just such a complicated thing. I think I remember from my CRRT days back in the PICU that calcium actually has something to do with this as well, and that's probably why it's part now of the diamond, which is almost as fascinating as that transition was smooth. So we can talk about hypocalcemia here for a little bit. Which is the newest member to the group here, right? So, we used to only talk about those three things: acidosis, hypothermia, and the coagulopathic problems. But now we've added hypocalcemia. And at first, its addition into all of this work was kind of this understanding that like giving a lot of blood products, containing a lot of citrate depletes your calcium. But like everything else, it's actually a pretty complicated system. And it's problematic. Like everything else in the diamond, hypocalcemia has an increased mortality, almost 2.5 times mortality, and it's an independent predictor of that. In children who are receiving as little as 10 to 15 cc's per kg of blood, which for those of us working in pediatrics, that is the dosage for your blood resuscitation, have been shown to see low levels of serum calcium. Also, interestingly enough, this idea of using blood pressure and heart rate as markers for instability, we do know that children are able to compensate longer. I think we all remember that being like bred into us from like day 2 or 3, right? But all of that can be normalized, and we can still be in a hypocalcemic state, either because you're getting a lot of blood products or other reasons, whether those are hepatic injuries. You have a crystalloid heavy volume resuscitation, as we've kind of mentioned, as being a generally bad thing. Crystalloids, normal saline, lactate ringers, zero calcium in that. And then because you have oftentimes, the other thing I never really thought about is because there's often some sort of skeletal fracture and skeletal breaking here, your body actually wants to try to shift a lot of calcium extracellularly to those areas to deal with injured bones and tissues. So all of these things, you don't, I try not to, I used to pigeonhole myself a lot with the calcium thing, because I'd be like, how many, units of blood? And then if it was greater than like 2, then you'd start thinking hypocalcemia. But these patients actually can become hypocalcemic for a lot of different ways. So how do we assess hypocalcemia? I mean, in a laboratory setting in the ICU, the answer is always going to be an ABG. Having arterial access in a trauma bay is typically a bad thing, because it means there's a bleed somewhere, and that's why you have arterial blood splattering, around your bay. But we typically will use VBGs as a surrogate, or we'll just kind of like do this thing clinically, right? We'll assess the patient. We know that low levels of calcium not only, affect things like clotting and stuff, but also affects your cardiac contractility. So patients who are showing hemodynamic instability, who have received a lot of blood products, maybe have an injury to the liver, kind of a good recipe for needing to give a dose of calcium. At Children's National, we have set trauma labs that are established for all of our patients coming in, depending on how sick you are. And ionized calcium is part of that workflow. Again, remembering from school that ionized calcium is the calcium that you can use. So that's kind of like the best marker for when you're trying to decide if your patients are hypocalcemic. And how do we correct it? I hope everyone's seated for this, but you just give calcium. And so definitely something to think about a lot of times in like resuscitative, especially if this patient progresses into a true traumatic cardiac arrest, which may be a different podcast, but is generally a bad thing. We sometimes forget about where calcium falls into that pathway. So definitely very important, all aspects of all of this. But again, it's a diamond, not because it has 4 points, 4 corners, but also because all of these things are related. All of them affect the other parts of this in almost like a negative feedback loop kind of mentality. So, Joanna, you touched briefly on hypothermia. Can you share with the group basically like what hypothermia does to the other factors that are associated with this diamond?
Right. So hypothermia, like you said, it's like once you get into this like diamond, once you get a little bit of everything, it's going to be a feedback loop. It's like you have to actually break the cycle. But like for acidosis, right, hypothermia slows your cellular metabolism, right? But so once you slow it, right, then your body has to work harder to do a lot of things that it needs to do. And it will work it often coincides with shock and hypoperfusion. So you're not getting the oxygen to the tissues. And so that will continue on your acidosis, right? You will have continued anaerobic metabolism. You'll have lactic acidosis that just like perpetuates the cycle. And also you decrease your myocardial response to catecholamines, right? And so once your heart's not working efficiently, right, you'll impair cardiac output, which also then leads to hypoperfusion, which then leads to exacerbating your acidosis. So it really does play hand in hand on how hypothermia affects your acidosis. And then you have your coagulopathy, right? Then with Hypothermia, where your platelets begin to dysfunction, right? Because your coagulation is really ties into acidosis as well as temperature. It's a very thin or small, has a very small, what am I trying to say? Leeway and what that will affect. What am I trying to say?
No,
It
you're right.
has a
You
very
got it.
small, it's very small space where you can go back and forth, right?
Small
So
therapeutic window, I believe, is the what the
thank
kids are
you.
calling it nowadays. Yeah,
Right.
trauma's a team sport. It's okay.
So once you have hypothermia, you'll have platelet dysfunction, coagulation enzymes, and the clotting cascades are very temperature sensitive. So once your temperature drops below 34, which we never want our patients to go below 34, but once you know, your activity really diminishes there. And your fibrinolysis, oh my goodness, this word is like always fibrinolysis is altered, right? So you won't get stable clot formation and even mild hypothermia, so anything below 36 will increase your bleeding risk, right? And will have to have higher transfusion rates. Um, so, Brad, you want to talk about how hypothermia affects hypocalcemia?
Yeah, so when we're hypocalcemic, again, this was kind of really the crux of really recognizing that not only is it associated with all these things, but it also kind of contributes to a lot of that stuff as well. So we talked a little bit about citrate and how in massive transfusions, citrate is used as an anticoagulant, and so you impart a lot of citrate into the body. You're going to eat up your calcium. Calcium cleaves to citrate in order to remove it. um, and so that part of treating the coagulopathic and the blood loss stuff is related to that. When you're cold, it slows down your hepatic metabolism, and it is your liver that it metabolizes your citrate, and so it exacerbates this citric toxicity because your liver metabolism has decreased, and so there's more citrate that's not being metabolized, hence the decrease in hypocalcemia as well. And then many of the clotting factors that exist are activated or somewhat related to the presence of calcium. It is a key cofactor to a large portion of the fibrin and fibrinogen pathways. And so when we have low calcium, all of these things are kind of tied into play. The last part of this that is all tied together, it remains to be acidosis. And again, many of those clotting factors are also very pH dependent. And so when we have an increase in acid, an increase of serum hydrogen, we are going to see negative effects into our clotting cascades. It also reduces cellular metabolism efficiency, which contributes to core temperature drop. So when you become more acidic, your body kind of like goes into this like terrified, I got to do what I can. I got to shunt what I can. Where am I going to put the effort and energy into? And oftentimes we end up losing a lot of that thermoregulation. And then also acidosis decreases cardiac function, which lowers systemic vascular resistance and deepens shock and increases clotting factor usage. So all of these things are tied and related. The coags too, again, play this role back and forth like we talked about. They're pH sensitive. Most clotting factors, when you start getting below 7.2 is like not a good place to be. Typically, even in critical care, when we talking about like levels of acceptable acidosis and things like that, 7.2 is kind of the basement of that. You really end up losing your ability to clot. Platelet function kind of stops completely. You have decreased thrombin generation as well, and poor adhesion. So all of these things obviously key to like creating some sort of clot. And even though
A very small therapeutic window. You got
that
it.
was so well said, a very small therapeutic window, absolutely. And even like, and because it's so small, even moderate acidosis actually amplifies your bleeding. So we don't have to wait for them to get down to 7.2 before we start seeing issues. Without staying too long in the acidosis window, the other thing that doesn't like a lot of acid is drugs we use. Things like sedatives, catecholamines, things that we need to use when things really start going bad. And I think the last kind of piece of all of this, that from like talking about how everything's related, is this how hypocalcemia is also related. So again, it impairs protein binding, reducing the amount of ionized calcium. It also decreases cardiac contractility, which we've kind of touched on and talked about. So I think we've talked ourselves into enough spirals and circles to recognize that not only do all four of these things have kind of pieces to them that are related to each other, but they also have independent factors of bad things happening, independent mortalities, independent length of stays. And that's why I think this relationship is so interesting. It's very rare to find relationships of things that in medicine that both have independent bad things happening, but then when you kind of bring them in the totality of the patient presentation, they kind of exacerbate themselves quite a bit. So don't do it, I think, is kind of like the general gist. Don't get near the diamond. But for those of us that are treating traumatically injured children, I think recognizing these things are important. And none of this stuff is solely a provider, dependent thing. I'm a big believer that all disciplines within the trauma bay parallel each other as professionals and can work as force multipliers in decision making. And so, don't think that I'm just a nurse. The dealing with levels of calcium and, tags and things like that have to do with the doctors. Like every bit of this, you as a nurse, you as a respiratory therapist, you as a trauma tech, surgery resident, we could go on and on. You all have this opportunity to recognize that these things are happening and trying to maintain priority within the trauma bay. I think with all of this, it's tough, right? Because there's so many priorities. There's so many things to do in a very short amount of time. And one of my sayings that I have been saying since I started at Children's that hopefully will start taking on is in trauma resuscitation, the damage is not always in the doing of a task. The damage is in the delay of doing something else. So when we talk about all of these things that are happening, we have to make sure that we recognize that these are priorities. Maintaining temperature management is a priority. Maintaining proper levels of serum calcium is a priority. Because if we let these things that could easily get in the wayside because someone has a distracting injury or has, some sort of, they have sedation issues or like airway. Airway is a big pigeonhole thing. Everyone kind of focus on the airway. We lose a lot of ground in the overall outcome measurement of these patients. Do you concur, ma'am?
I do, and I think we do get so caught up in our own tasks that we need to complete, especially in the trauma bay, that we tend to do a lot of it, a lot of nursing, I would have to say, do focus on getting IV, making sure access, which is very important. But understanding that having a full set of vitals, understanding the what the presentation is, to especially including the temperature, right? After getting your blood pressure, making sure the temperature is done so that we understand what the patient is presenting as and what we need to do to prioritize his or her care, is part of your trauma role, and knowing that temperature does play a very big part in that. Understanding if the patient is coming in cold and how we can do to warm them, or what we can do to prevent the patient from getting cold, that will also promote this the patient going into this trauma diamond of death, which we don't want ever to go into.
No.
No.
And Joanna and I keep harping on this temperature thing because I think right now in our setting, as we're looking at our key process indicators for success in our trauma bay, this is something we really want to try to focus on as a group. We know that we have an issue with it. I don't think we're alone in that, from a trauma system standpoint, but we also recognize that it is something to get early. I think when I first started hearing about this, I was like, okay, we'll get one when we go upstairs. As a former type A ICU nurse, I know I would always be like, what's the temperature? And the ED would be like, not right now. But it's actually, the earlier we get it, the better we can have a trajectory, because the other part of managing trauma patients has to do with balancing futility and recognizing that the work that we're putting into these patients and their bodies, the work that we're putting into our teams, their mental bandwidth can only take so much. And so futility, especially in pediatrics, is a really challenging thing that we have to try to balance with hope and, trying to get everything that we can possibly do. But recognizing a patient coming into your bay who has a core temp of 34 is exceptionally different than a kid that comes into your bay who, is normal thermic. And that is going to help a lot of large and challenging decision making early on, which I think is super important. So really, to say it all again, to summarize it up, I would basically say hypothermia is an emergency. It should be treated as such, just like hypotension, just like hypoxia. I think it is not just a side effect of being outside. I don't think it's a side effect of just being exposed in a trauma bay. And I think it's important. I think early calcium leads to better outcomes, and recognizing that there are many different functional pathways about how patients lose calcium, and try not to get pigeonholed in there into thinking that patients who become hypocalcemic are only patients who receive large volumes of blood products. It's just better for the patients, reduces their mortality, reduces a lot of bad things that we don't want to have happen. I'd recognize that coagulopathic processes may be present even if vitals are normal. So, just because you have a patient who rolls in, who is, complaining of a little stomach pain, yes, we recognize that there are hidden compartments that patients can bleed in, and that's kind of where our focus is, but recognizing that cascade of endothelial damage and using all of your goodies, as I believe Joanna called them, starts early in the process. And then lastly, lactate, acidosis. Goal-directed lactate clearance needs to be central to how we manage patients in the trauma bay. Stay away from bicarb. I will come find you. And other than that, just do the thing. Teamwork is the most paramount. Communication, all these things that we never have a problem with in the trauma bay. Maybe poor communication could be part of the next arm of the trauma diamond. The trauma pentagon of death we could add poor communication, teamwork into that. Maybe I'm onto something there.
We'll have to get a lot of buy-in from
patent pending idea. Yeah, well, I'll get the abstract submitted. Anything from your vantage point, Joanna? Things that you're excited about, moving forward with this temp stuff. Other thoughts for those maybe who don't take care of a lot of kids, and how this could affect their care?
Yeah, so I think this is a key component in understanding trauma patients, right? Understanding that they can go into this cycle of how they to their demise, essentially, right? Because it's the diamond of death. And that trauma patients are a little different. That's why we do harp on certain things on in the trauma bay and in the care that they are provided. So temperature is one thing, but if they do have a injury that does have a bleed, that we do go straight to blood rather than having to fiddle around with giving boluses, because we don't want to dilute anything and make that coagulopathy worse by diluting it. So just understanding that in the trauma bay, if the patient is hypotensive, that we're not going first for for crystalloids, but you are suggesting, we do have blood in the trauma bay. We do have that readily available to start the massive blood transfusion, and nurses definitely can be the one that suggests it and say, hey, why not give them blood?
Yeah, awesome. Well, I think we hit this one on the head. I think this was a good conversation. Initially when we wanted to do this podcast, we were really focused on the temperature thing, and I think we recognized pretty quickly like it's kind of hard to talk about that without talking about the other aspects of this. So I think this was a good run through. Hope this helps people. We're going to end it for today. Really appreciated everybody's time. Hope they found this helpful. We're going to have a link at the end of this for an evaluation so we can get you some CNE. But that's all I got. Until next time, we'll see you guys later.